Great. Okay,
You
so
know?
thanks. Perfect. Thanks everyone for being available to join this final results presentation from the Nigeria 2024 ACTwatch Lite study. I'm Paul Blanchot, and I'll be joined by Caitlin Woolheater, my colleague, and we'll be presenting some key results to you all today. We anticipate the presentation will take around 40 minutes, and then there'll be time for Q&A and discussion at the end. If you have any questions, please feel free to drop them in the chat as we go. And if I can, I'll address them in real time, and if not, then we'll come to them at the end. So yeah, please feel free to keep the questions coming. So just a quick outline of what we're going to look at. I'm going to give you a background on ACTwatch Lite before talking a bit about indicators, study design, and how we implement it in Nigeria. We'll be looking at some just key sort of trend results from historic ACTwatch and then ACTwatch Lite data before moving on to the 2024 key results. And then I'll hand over to Caitlin, who's going to walk us through the toolkit that's coming out of this project that we're really excited to share with you. Okay, so um, really as background to this project, I think an important point that we want to underline is that in many contexts in sub-Saharan Africa, the private sector really is key for malaria case management. It's the first point of call for many in sub-Saharan Africa. Um, Progress towards malaria control and elimination, and particularly thinking about the response to antimicrobial drug resistance, is likely to lag behind if private sector engagement isn't prioritized. We think that one of the biggest challenges is in accessing quality, timely data on the private sector. In this current context of dynamic and uncertain funding, that historically has often prioritized public health system support for malaria case management, we think it's likely that there'll be an increased burden on private sector supply chains. And so now more than ever, the private sector is an important thing to be thinking about and measuring. Tracking the effects of funding changes on the availability and volumes of key malaria commodities is likely to be essential if we want to ensure and be able to track adequate case management. The map that you can see on the left of the slide here is just a very simple descriptive representation of some DHS data from the most recent DHS or MIS from each country shown, showing the proportion of children, the percentage of children with a fever for whom treatment was sought, who went to a non-public sector source of treatment or advice. And what you can see here is that in a number of countries in sub-Saharan Africa, a really large minority, or indeed a majority, of children under 5 are being provided with care from non-public sources. So ACTwatch Lite is a response to this need for data on the private sector. We're funded by the Gates Foundation, and we've completed data collection in 3 countries to date. There you can see on the map that we've completed in Benin, Cameroon, and now Nigeria. And of course, it's the Nigeria results that we're presenting today. In addition, the Gates Foundation has provided some funding to a local NGO in DRC to pilot the toolkit that we've created with data collection starting very shortly in DRC. And then we've had interest from a number of national malaria control programs in other countries that are shown in light blue. Um, what is ACTwatch Lite? Well, we collect malaria treatment, diagnostic, and provider data from formal and informal private sector outlets and their supply chains. So this is really responding to that need I mentioned for visibility of what's happening in the private sector. The approach allows data, the methods, and tools to all be rapidly available for national programs and other stakeholders like regulators, pharmacy councils, and so on, to allow for an up-to-date understanding of what's happening in private sector malaria markets, but then also to understand what some of the drivers of performance in that market might be, so that decision making can be informed by those data. The idea really is that we're collecting data that informs decision making for private sector case management. We work closely with our stakeholders throughout the process to ensure that the data that we're collecting is responsive to their needs, that it's fit for purpose. And I believe we have some of the Nigeria stakeholders in this call that I would love to hear from as we go through the presentation. The direct policy and program effects of the project are already being demonstrated and tracked. And the toolkit, as you'll hear from Caitlin later on, is being reviewed by a WHO assembled group of experts in June, July this year, so shortly. We often get asked what's light about ACTwatch Lite. Um, the implication really in the name is that it's lighter than ACTwatch in its original form. ACTwatch originally was a study implemented by PSI and funded by the Gates Foundation, among others, to collect data on public and private sectors in a number of countries between 2008 and 2016. Um, the new incarnation of ACTwatch Lite really aims to achieve uh, the same quality and depth of data and insights, but more quickly and more efficiently. So we have a shorter timeline. We collect data more quickly. Specifically, timelines for data collection and entry have reduced from 3 to 5 months to around 1 to 2 months. Data management, analysis, and production of results has gone from anything up to about 8 months to about 8 weeks. We also conduct now a combined outlet and supply chain study. So the study's combined to be more efficient and to give a more comprehensive view of the total supply chain for antimalarials and malaria diagnostics. And third, we have a modular and transferable design. I've mentioned already the toolkit that we'll talk about more later, but really the idea is that our study can be picked up by other countries and can be made applicable to contexts with different sort of types of formal and informal anti-malarial markets. Um, Really, the speeding up of the timeline is one of the key parts of the lightness of the study, I guess. And in the blue call-out box, you can see three of the key things that we think are essential and are key to the success of ACTwatch Lite and that make it lighter. So we collect data electronically. This means that there are a bunch of kind of efficiencies built into the process of validating and checking data. Um, in addition, we have a proprietary database of anti-malarial products and RDTs that allows field workers to conduct searches from the database in real time, and it reduces the risk of data entry errors on the part of field workers. It also just makes the process a lot quicker. To date, we've got over 2,000 unique anti-malarial drugs and around 70 RDTs in the database. And then finally, we have designed an analysis and output approach that allows for automated tables and figures generation that will also be a part of the toolkit. So all of these things will go into the toolkit and aim to make this kind of study more uh, cost efficient and speedy to implement. Briefly, the key indicators for ACTwatch Lite aim to capture the main features of the private sector supply chain. So all levels of the supply chain, we look at anti-malarial and RDT availability, price, market share. We also look at retail and wholesale market composition, different characteristics of businesses and providers and so on. And then further up the supply chain, when we talk to importers, distributors, and local manufacturers, we we find out about their distribution footprints for geographic reach, range, and number of consumers. We look at importer, wholesaler, manufacturer, products, pricing, sales, competition, regulation. So really trying to understand all aspects of the supply chain that would influence the availability, price, and market share of antimalarials for consumers. Okay, so that's an overview of the study across the board. Now thinking specifically about Nigeria, I just have a couple of slides to explain what we did in 2024 for ACTwatch Lite. The study design that we used in Nigeria in 2024 allowed for full private sector measurement in the 3 states that we went to that were selected through stakeholder discussions and really aimed to have geographic variability and epidemiological variability, but within the kind of the budgetary constraints that we have on the project. Um, we used a 2-stage cluster sample design, which was stratified by these 3 states and then urban rural. Using PPS, we selected 125 wards, which are the main study sites, and then we conducted a census of all outlets within those 125 wards. So that means that any outlet in the private sector with a capacity to stock or sell anti-malarials or diagnostics was eligible for inclusion in the study. We can see the types of private sector outlet that were included in the blue box just below the map. but really we aim to have both formal and informal sector outlets. Um, the census approach involves field workers having both lists of outlets, but then also just going door to door within the geographical bounds of the ward to ensure that all outlets are included. We include outlets, wholesalers and suppliers based on information collected from the outlet surveys, as well as direct sampling of some key supply chain actors that we were aware of through stakeholder engagement. We also conducted a pilot e-pharmacy study where we attempted to conduct an audit of products on e-pharmacy websites in Nigeria. I won't be talking about that in any detail today, but please have a look in the report for the section on e-pharmacies to learn more. And then we also conducted a sample of importers and manufacturers who were interviewed qualitatively to really get a deeper understanding of what happens at those higher levels of the supply chain. So this is a really busy slide. I guess what it's telling us is that data was collected from July to September last year. In total, we went to just over 4,100 outlets and conducted full surveys with them of just over 4,500 total outlets that were screened. And you can see here in the three maps, the selected wards. So these orange areas within each map are areas in which we went to every single private sector outlet to collect data. And we collected data on every single anti-malaria product that each of those outlets had. And my last slide on the background for the Nigeria study design is really just about kind of quality control and the approach that we take to training. So training is pretty comprehensive. It's a 12-day training. In Nigeria, we conducted a training of trainers in Abuja, which covered all of the main kind of elements of the study. A really important thing in ACTwatch Lite is that we need our field workers to feel confident collecting accurate data about anti-malarial products, which means lots of role play and practical exercises, as well as classroom learning about anti-malarial products so that they're able to capture active ingredients, dosage, strength, etc. Um, we worked through a research agency, Transil, who then cascaded training down at state level using our standard package of tools and making sure that they're adapted to the local context. And then in terms of data collection, we use Survey CTO to collect data electronically. These are preloaded with the database that I've mentioned of anti-malarial products, and contain all the standard elements of an electronic data collection tool. Fieldwork was overseen by, of course, transfer field supervisors and PSI, but also stakeholders who we invited to attend and oversee fieldwork to help with quality control, but also just to have an experience of what happens in the field in this kind of study. Um, and then real-time data quality and fieldwork monitoring was done by PSI and Transil, and including on the right here, you can see a map from Google Maps where we plotted all of the fieldwork locations. So in real time, we could see where field teams were and monitor their progress and ensure uh, protocol adherence in terms of geographic spread. Okay, so I've just got a couple of slides that situate the 2024 results within the sort of history of ACT Watch results in previous years in Nigeria. I just note that they're not directly comparable because in previous rounds of ACT Watch Nigeria, uh, study was stratified by geopolitical zone rather than state, and so these are kind of indicative rather than perfectly comparable, but it gives you an idea, hopefully. So I think what we can say is between 2015 and 2024, PPMVs, which are kind of drugstores, slightly less formal but still within the formal sector outlets, continue to be the most commonly found outlet type with anti-malarials in stock. In 2015, they were called drugstores in our reference document, whereas in 2024, they're called PPMVs, but the yellow color remains. These continue to make up the majority of outlet types in all three areas. When we look at ACT availability since 2015, in fact, since 2009 through 2015, there have been sort of round on round increases in the proportion of outlets that are stocking ACTs in all three study sites and their equivalent geopolitical zones previously. Um, so we're now seeing that in excess of 80% of outlets across all three states have ACT in stock on the day of the survey. This is up from below 40% in 2009. And again, just quickly to give a sense of trends, when we think about market share, ACT market share has continued to increase over time and now makes up the majority of the market in 2024. So it's a bit confusing because the colors have changed between survey rounds, but what we can see in 2009, in the sort of thick black box, is that ACTs represented a vanishingly small amount of the market share, increasing round on round. And by 2024, um, at least two-thirds of the market is ACT in all three states. But in fact, in Abia and Lagos, over 90% of the market share is ACTs. At the same time, SP market share has fallen from around 30% nationally in 2015 to less than 10% in 2024. And finally, injectable artemisinin were largely absent from the private sector in 2015, but now represent uh, varying considerably by state between 1% and 22% of the market. So actually in Kano state, injectable artemisinin now represent 22% of the market. Okay, so that was some trends. I'm now going to turn to the 2024 results more generally. So as we've seen, PPMVs represented the most frequently identified type of outlet with antimalarials in stock on the day of the survey, with some variability by state. In Abia and Kano, PPMVs really are most outlets with antimalarials in stock. In Lagos, they're around 50%, 56% of outlets, while pharmacies represent about a third of the market. Meanwhile, the market composition for diagnostics look quite different by state. So in Kano, 63% of the outlets with any testing available were PPMVs, whereas in Lagos, 58% of the outlets with any testing available were laboratories. In Abia, the types of outlets were more mixed, but in fact, the number of outlets with testing available was quite low in Abia. And so, um, yeah, we advise interpretation with caution of Abia results. But really, Kano and Lagos looking quite different for diagnostic market composition. The availability of any antimalarial and then any ACT was high in all three states. In Abia, 99% of screened outlets had any antimalarial in stock and 98% had an ACT available. So that means if an outlet in Abia has an antimalarial in stock, it's extremely likely to have an ACT available. In Kano, 85% of outlets had any antimalarial, while 71% had an ACT available. And in Lagos, those figures were 88 and 85%. Um, so overall high and good levels of ACT available. Um, where an outlet has any ACT available, um, it's almost certain to have AL available. AL is the most commonly stocked ACT, and really leading the share of all ACTs available in outlets. It's followed by dihydroartemisinin and piperacin, DHA-PPQ, and then ASAQ. So DHA-PPQ is the second most commonly available ACT. Around 33% of outlets in Lagos had this available. It was mostly found in pharmacies. ASAQ was found in 24% of outlets in Lagos, but really AL is predominant. Um, we're proposing a novel indicator for private sector readiness for multiple first-line therapies. And that here is defined as the availability of two or more types of ACT in any outlet. So what we mean by that is if an outlet has AL and ASAQ available, then it's marked as being sort of MFT ready. What we're seeing is that the level of MFT private sector readiness varied considerably by state. About 29% of outlets in Abia and 21% in Kano had two or more ACTs available on the day of the study. 41% of outlets in Lagos had two or more ACTs available. And this is largely accounted for by the predominance of pharmacies in the Lagos market. Pharmacies tended to have more ACTs available. And so that's what we're seeing here. So the availability of severe malaria treatment was over 75% in Kano outlets and much lower elsewhere. So yeah, this is largely accounted for by PPMVs in Kano having severe malaria treatment available on the day of the study, whereas PPMVs elsewhere tended not to have any severe malaria treatment available. So thinking specifically among those severe malaria treatments, thinking specifically of injectable artemisinin, what we're saying is that their availability was highest, unsurprisingly, in Kano, and that most of the availability of severe malaria treatment is accounted for by injectable artemether availability in Kano. So 67% of Kano's outlets had injectable artemether available on the day of the study. Um, Much lower proportions of outlets had these medicines available in Lagos and Abia states. So now, if we look at the availability of malaria diagnostics amongst outlets with anti-malarials in stock, we see quite a lot of variability by state. So why are we looking at this? Because in order to have an adequate test and treat implementation, we would need to have testing available in outlets that have treatment available. And what we're seeing is that in Kano, uh, 28% of outlets that had a treatment available had testing available on the day of the study, and much lower proportions of outlets in Abia and Lagos. So 2% in Abia and 6% in Lagos. Um, Across all three states, microscopy was much more rarely available in the private sector than RDTs. And in fact, when we found RDTs available, almost all of them were WHO pre-qualified RDTs. And so if an outlet has an RDT, it's very likely to be a pre-qualified RDT. So now I want to show the results for anti-malarial market share. And what we can see in green is that ACT's different shades of green here, and they're really predominant in the markets of all three states. And AL is the most common ACT and is accounting for the largest proportion of market share in all three states. So in Kano, 63% of the anti-malarial market is ACTs. Um, and in Lagos and Abia, that's between 91 and 93%. SP accounted for 10% of Kano's market share, while injectable artemisinins accounted for 22% of Kano's market share. We did not find any oral artemisinin monotherapies or rectal artesunate in the private sectors of any of these three states. So when we disaggregate market share by outlet type rather than state, what we can see is that PPMVs are really accounting for the largest proportion of anti-malarials being distributed across the three states. Note here that I've combined the three states together for simplicity, but in the report that we'll share a link to at the end of this presentation, you can see the results disaggregated by state. So yeah, what we're seeing is that PPMVs are accounting for about 72% of all anti-malarials being distributed in the private sector of these three states. Pharmacies about 20%, and then for-profit health facilities about 5%. Private for-profit facilities include hospitals and clinics. Most of the SP and injectable artesunates being distributed are being distributed through PPMVs. Now to look at the market share for diagnostics disaggregated by outlet type, what we can see is that laboratories account for the largest proportion of market share across the three states combined. Almost 60% of all diagnostics being distributed in the week before the study were microscopy in laboratories, while PPMVs account for 28% of the diagnostic market share. And almost all of the market share in PPMVs is RDTs, and almost all of that is WHO PQ RDTs. Now this slide is sort of intentionally a bit of a mess, I guess. And what we're showing is that the market share by manufacturer and brand is really complex in Nigeria, according to our results. So we've highlighted in the table different brand manufacturer combinations that account for more than 3% of the market share in any one state. And what you can see is that there are very few that account for even that proportion of the market, and that there are a ton of different products and manufacturers combined. And indeed, the sort of all other option accounts for about half of the market share in all three states. So yeah, a big messy picture. We also look at product stockouts. So we ask providers to report stockouts of different product types in the previous 3 month period. What we're seeing is that Kano has the highest rate of stockouts reported, with around 16% of outlets reporting stockouts of artesunate, 16% reporting stockouts of SP, 8% chloroquine, etc. Stockouts were less frequently reported in the other two states. Um, However, RDTs across the board across Kano were the most commonly reported stock out, with 32% of outlets in Kano reporting a stock out in the previous 3 months. We also collect data on price that I'll present a couple of slides on here just to give you an overview. Um, so what we can see is that median ACT prices, as standardized into adult equivalent treatment doses, um, vary by antimalarial type and also by state. Across the board, AL is the cheapest, but AL, DP, DHA, BPQ, and ASAQ are all quite similar in price, while artemisinin PPQ and arterolene PPQ are much more expensive. And so while we haven't included SP and chloroquine in this graph, our results suggest that they're priced quite a lot lower than ACTs, between 300 and 800 naira, while ACTs are priced between 800 and 1500 by state. We also have price for diagnostics. And what we can see is that the median price of microscopy was slightly higher than RDTs in Abia and Kano, but the same in Lagos. But I think perhaps more interestingly, uh, that microscopy and RDTs are priced higher than the cost of an adult equivalent treatment dose of ACT in across the board, essentially, but certainly in Abia and Lagos, diagnostics are much more expensive than treatment. In terms of business practices, we ask about reporting into HMIS. And what we find is that a low proportion of private sector outlets in all three states report that they provide information into any health information system, ranging from 3% in Abia to 29% in Kano. Among those who do report, uh, the most common form of reporting is either directly to government or because of a specific project or NGO, with relatively few outlets reporting that they feed data directly into DHIS2. Okay, so I just have one very brief slide to present on the supply chain, but much more information is provided in the Word document report. Um, I guess a bit like the table showing brand and manufacturer, what we can say is that supply chain is quite complex. We collect data both from the bottom up and from the top down on the nature of the supply chain and the relationship between different parts of the supply chain. The arrows on this figure indicate um, sort of bottom up reporting of source of anti-malarial and RDT products. Um, this looks quite different in each state. So while the overall form of the supply chain is similar in each state, the relative importance of each of these arrows looks quite different. And while we don't really have space to present those slides here to you today, we do have much more information about those given in the report. So take a look if you're interested in understanding where people report getting their supply of antimalarials from. So I'm going to finish my section just with some key takeaways that we have from uh, the disseminations that took place both at state level in Nigeria and at the federal level with our stakeholders, and with subsequent conversations that we've had since. Um, so first, I think it's clear that the market's pretty dominated by PPMVs. They're really key in delivering malaria treatment, but we know that they face gaps in training, supervision, regulation, have relatively low levels of reporting. And so there are potentially opportunities there for strengthening their engagement with those systems. We see that ACT and antimalarial availability overall are both high. There's no dominant manufacturer, and the market's pretty diverse. We see considerable variability between states, both in terms of availability, but also pricing. As well, I would add, I guess, as brand and manufacturer type. Um, AL is dominant, and the injectable monotherapy market share in Kano is pretty high, and appears to have grown since the previous round of ACTwatch. The availability of diagnostics represents a gap. We see a gap between levels of treatment and diagnosis in all three states. We see relatively low volumes of RDTs being distributed, and although not presented here, we see relatively low knowledge of RDTs in the private sector outlets that we spoke to. There are price disparities between ACTs and RDTs, and when we think about private sector consumers accessing treatment, it seems likely that having a more expensive test than treatment would discourage testing before treatment. And so that's a potential area of interest and concern. We see relatively low levels of reporting, training, and supervision reported in the private sector in the three states that we studied. So this presents opportunities both to improve reporting from private sector outlets, from pharmacies and PPMBs, but also to integrate training and supervision into those outlet types. And finally, the supply chain and stock out challenges are complex. We see that there are different supply chains operating at each state level. Um, in stakeholder discussions, there have been sort of ideas around opportunities for coordinated wholesale centers. And we would argue that deeper investigation into patterns of stockouts would be really useful to understand what's happening across the supply chain. Okay, I think that's all from me. So I'm really happy now to hand over to Caitlin, who's going to walk everyone through the ACT Lite Toolkit. Thanks, Caitlin.
Sure, yeah. Hi, everyone. I'm Caitlin Woolheater. You can go to the next slide, Paul. Okay, so as Paul already mentioned at the beginning of the presentation, the private sector is providing some proportion of malaria case management across the malaria endemic world, and just as often as private sector or care seeking outside of the public sector is happening, we have this information gap that ACTwatch has historically filled since its origin or the project inception in 2008. And the ACTwatch Lite project has been revitalization and modernization of the original ACTwatch studies. And Paul already discussed some of the changes there, but just to kind of walk through the journey of updating ACTwatch. First, the scope was refined. This meant that we consider the priority indicators from ACTwatch, but also narrow the scope to specifically focus on the private sector while also expanding to some degree to include the full supply chain in these assessments. We also digitalized the tools such as the questionnaire. We created a database of products, antimalarials, and RDTs so that in the field these can be searched instead of manually entered for known products, and streamlined a lot of the analysis process. The next step then was piloting these in 3 countries, in Benin, Cameroon, and Nigeria. And through this, we refined all the tools, both lessons learned the PSI team, as well as feedback from the malaria programs and other data users. And the next step will be for the WHO to review the toolkit package as it is in June, early July, before finalization. Next slide. So what is the ACTwatch Lite Toolkit? More specifically, it is a standardized package or a package of tools that have been standardized so that we're capturing the same indicators or qualitative themes. And everything is designed to be modular so that for each implementation, you can refine the scope to your specific context and adapt the tools to that scope. So alongside all of the tools that are used to implement each phase of the study from project's initiation to dissemination and data use, we have a manual and implementation guide. But then within each tool itself as well, there's instructions for adapting that tool and using it so that they can almost function as standalone tools. And the study materials are for both the quantitative market survey component as well as the qualitative interviews that capture those other supply chain levels. So next slide. This table presents the toolkit content specifically. So as I mentioned, there's the manual and implementation guide. We have an indicator table that outlines all indicators that can be assessed with the quantitative tools in the toolkit, as well as qualitative themes that are captured through the qualitative interviews. There's a desk review guide and guidance on stakeholder mapping, a protocol template and references from the pilot, tools for budgeting and work planning, a tool for PPS sampling, the product master list that we've mentioned, so database or data sets of known intramalarials and RDTs. Terms of reference templates for key staff, as well as for a research agency. Very extensive training materials for both the qualitative and quantitative components. Qualitative interview guide, quantitative questionnaire, syntax for analyzing all the quantitative data, and the syntax then outputs tables into Excel results workbooks that are set up to generate formatted tables as well as some charts and a report template. So again, all of the materials that have been used during the pilots have been packaged and refined, sort of mapped to the indicator table or qualitative themes. Yeah. Let's move to the next slide. So I've already said this multiple times, but all the tools are mapped to the quantitative indicators. There's a screenshot here of what that indicator table looks like. Include a detailed description of each indicator and where within the questionnaire it's captured. And then in the questionnaire, it's also matched to the indicators. And similarly with the qualitative questionnaire, it's mapped to key themes. Next slide. So the expected output from the study implemented using the toolkit would be these tables and charts for each of the priority indicators. These can be input into the report template. There's instructions within that template on what goes where and like some means of interpreting the data. And these results are expected to provide evidence to decision makers that would inform improvements for case management in the private sector, highlight key gaps, etc., as you've seen with the Nigeria study. Next slide. So this is my last slide, just why use the ACTwatch Lite toolkit? Why have we developed this? First, it offers a relatively fast and cost-effective, also scalable solution to filling this data gap that we have with private sector case management. ACTwatch specifically is now a standardized set of indicators that can potentially be tracked over time in places where this study has been implemented in the past, or it can be implemented now and designed to monitor progress moving forward, or potentially measure the impact of interventions. Since everything is tied to this indicator framework, it's like flexible to refine the scope for a specific study. It could also be quite easily adapted to include or assess other disease areas or fit within any routine M&E supervision that is already existing or operating for the private sector. And lastly, the assessments promote evidence-informed decision-making, providing key or priority indicators to design interventions for private sector case management. So next slide. I think that's it. Yes. So big thank you to all of the stakeholders that supported the Nigeria study. Paul, do you want to take over?
Thanks, Caitlin. And yeah, so I realized I didn't have my camera on before. Apologies. A huge thanks to our stakeholders that are listed here and many others that maybe aren't on this list. Apologies. I wanted to open the floor to questions. And also just to thank Caitlin for talking about the toolkit and to say that if anybody would like access to the toolkit, before it's been through the full technical review by WHO, either to see the draft and use some of the tools or just to know more, please look on our website or reach out to me directly at my email address here. But I'm going to stop there and see if we have any questions. Thank you.
There's no questions in the chat either, so I guess we've done a good job of being crystal clear.
Or just overloaded everyone with information. Well, in which case, thank you so much. And please, yeah, do drop questions in the chat. Um, so I see a question here. What is the prevalence of severe malaria in Kano? Actually, that's a great question that I don't have the answer to right now. But certainly something I can get back to you on if we're able to find that information. I think when we presented the severe malaria treatment availability results to both state level and national stakeholders, there was some surprise that the availability of severe malaria treatment was so much higher in Kano. And I know that we have some national stakeholders available on this call who perhaps would like to step in and add to my response. But our understanding is that the use of intramuscular injectables for non-severe malaria treatment may be quite prevalent in Kano, and so that's why we're seeing such a high level of their availability and market share. So we believe it's possibly a non-indicated use of intramuscular artemisinin injectables. But yeah, the question is extremely pertinent about prevalence of severe malaria. I don't believe that we have cause to expect it to be substantially higher than elsewhere in the country, though. Perhaps I'll just pause to see if any of our national program colleagues would like to add.
Yes, Paul, thank you.
Thanks.
This is Dr. Shekaro.
Dr. Checker, welcome. Thank you. Please go ahead.
Yeah, thank you. Yeah. So, well, in line with that question and your response, of which you are on point, you realize that the treatment or utilization of severe malaria injectable artesunate it's high in Kano because of the prevalence. In some of the audits that we have carried out and even some retrospective studies on severe malaria, we have consistently seen Kano to carry a major burden of severe malaria in the country. Though we do not have some sort of surveys that, extrapolates result of severe malaria prevalence or the standalone, rather than the usual malaria indicator survey, of which Kano, which is in the northwestern part of the country, is part of those states that has a high prevalence. I think it's above 30% of general prevalence and not just severe malaria prevalence, but based on incidence of severe malaria, Kano is seen to be one of those states with such high prevalence in Nigeria, and the reason for the high utilization of injectable artesunate. And Kano, for example, is the most populous, or one of the most populous states in the country, I think side by side with Lagos State. And so which also will buttress the fact of having that severe malaria incidence, coupled with the fact that the prevalence of malaria is very high, or Kano is one of the states with the highest prevalence in the country. So leading to this outcome that you're seeing from this result. So just to reiterate what Paul had said as well. Thank you.
Dr. Shakara, thank you so much. It's appreciated to have your reflections on that. And perhaps, Jacques, I can see that your hand is raised. Please go ahead.
Yes, thank you, for this presentation. So I think I have two questions. It looks like the second question. Okay, there's some kind of response for that. So I saw on one of the map, like they have additional country where NMCPs expressed like interest in the implementation of ACTwatch. My question is that will the project meet the expectation of those countries? And the second question, I'm saying like injectable monotherapy market in Kano is quite high. So when you are talking about monotherapy, like injectable, are you referring to what type of drug? Is it artesunate injectable, quinine injectable, activated injectable? And I want to know if that is in line with the country law guideline with regard to severe malaria treatment or uncomplicated malaria treatment. Thank you.
Thanks. Two great questions, Jacques. And I'll try to respond, but invite others to contribute as well. So regarding the other countries where national programs have expressed an interest in conducting this type of study, um, as always, this is a question of funding. The purpose of our toolkit is to make this approach and methodology accessible to any country that would like to conduct this study. With or without technical assistance from my team or others, of course. Uh, we are uh, currently in a situation where the toolkit has not been technically reviewed by WHO, but once that happens in the coming months, we believe that this methodology will become perhaps more eligible for funding from sources beyond Gates, our current donor, and so we're hopeful that countries will be able to conduct this type of study in the near future. We remain available to provide technical assistance, but also help with designing studies beside that, and for discussions on the practicalities of doing an ACTwatch Lite in any country. And I really encourage people to reach out to my email address that's on the screen if you have any questions, or if you believe that your national program would be interested in conducting an ACTwatch Lite study. Thanks for that question. The second question was about injectable monotherapies. In fact, the majority of the injectable monotherapies that we found in the study were injectable artemisinin, so relatively low levels of injectable quinine, chloroquine, but mostly injectable artemether, arteether, and some artesunate. Um, the national treatment guidelines, I believe, for severe malaria specify injectable artesunate and other injectable artemisinins as alternative options, with quinine also recommended as a second line option. But I invite the national program to correct me if that's incorrect. So yeah, what we're finding is injectable Artemether mostly, which we think we're finding in higher quantities in ppmvs in Kano because it's an intramuscular injection, and so perhaps more accessible in a less formal environment. Thanks for that question. I see there's a question from Tin in the chat as well that I'll try to address now, and then please everyone feel free to jump in. So Tin's question is says, I'm interested in the finding that many outlets are stocking multiple ACTs. Do we know why this is happening? How providers decide which ACT to sell? And any insights into why some clients choose to pay more for options like DHA PPQ? Um, that's such a great question, Tim, and I'm not sure that I have a good answer actually. We're seeing that pharmacies tend to have a wider variety of ACTs available. So they in general have, I guess, a large number of anti-malarial products anyway, and then just a broader variety of ACTs. We don't have information on what determines ACT choice among consumers. Um, I would speculate that price plays a role, which is why AL is such a predominant product. But we don't have consumer level data because the study really focuses on outlets. But it's certainly something that we'd like to understand better. And I think understanding consumer demand for diverse ACTs is going to be a really important part of the antimicrobial drug resistance kind of response at MFD. Um, if consumers in the private sector request a wider variety of ACTs, then I suspect that the private sector will provide them. But as it stands at the moment, we don't have good visibility, a good understanding of what the mechanisms are um, for that choice. I'm sorry, I don't know if that really answered your question. Others are welcome to jump into. Thanks, Tim. I see your comment. Yeah, we likewise look forward to the toolkit being finalized and reviewed. I just wanted to open the floor to Dr. Shekarau or others from the National Malaria Elimination Program in Nigeria. If you'd like to say a few words before we close the session, um, yeah, I just want to give you that opportunity. No problem if not.
All right, thank you so much, Paul. Let me first of all send in the apologies of the national coordinator, Dr. Nena Eligwe, who has asked me to represent her here because of other, uh, similar engagements that are of equal importance. But, because of the World Malaria Day that's approaching and many other programs, she's unable to join. So we also want to really appreciate everyone for joining this important dissemination meeting, which was through the collaboration with the PSI. And we have conducted this survey, which is going to be really useful to the country in terms of reshaping the private sector malaria intervention in the country. And now we have a good perspective of what is happening in this sector. It's been a while that this kind of survey was conducted in the country. And now that we have the final result of this, we will continue to work with all stakeholders to implement the actions and recommendations from this survey to drive the private sector malaria intervention forward in the country. Also, the current government in Nigeria are really looking to explore areas of improvement in deploying intervention in the private sector. And this survey is just timely for us to inform decisions that will be taken by the federal government of Nigeria. So really appreciate this, and we appreciate everyone that is on this call. Again, particularly the PSI, whom we collaborated with to conduct this survey. We are so grateful for this support and collaboration. And I know this is just the beginning. We'll continue to collaborate to implement the recommendations as well as other areas that we would be collaborating with in the future. So once again, I convey the appreciation of the National Coordinator and the NMEP at large for all this all-important survey result dissemination. Thank you, everyone. And over.
Wonderful. Thank you so much, Dr. Shekara, representing the National Malaria Control Program, National Malaria Elimination Program in Nigeria. And thank you all for your participation. The slide deck will be available after the presentation, and we've obviously recorded as well. So let us know if you need access to that. Thanks. I hope you all have a great rest of your day. And thanks again for taking part.
Bye, everyone.
Thank
Bye.
you.
Thank you,
Bye.
Paul. Thanks, Caitlin. Thanks, Dr. Sheka.
Bye.
Bye-bye.